Assalamu alaikum warahmatullahi wabarakatuh. Good evening, ladies, or good afternoon, I should say, colleagues. My name is Osama Al-Alami. I'm the Regional Medical Advisor for Novo Nordisk in Qatar. And welcome to the Novo Nordisk Symposium with our esteemed speaker, Dr. Goran Petrovsky, for the talk entitled Faster Aspart and Innovation in Prandial Insulins. Dr. Petrovsky is an endocrinologist and a professor coming from University Clinic of Endocrinology and Medical Faculty at Skopje, Macedonia. He's a consultant endocrinologist at Sidra Medicine in Qatar. And as you can see, a very impressive biography, but without any further delay, it gives me great pleasure and honor to welcome Dr. Petrovsky onto the virtual stage. Dr. Petrovsky, the floor is yours, sir.
Thank you, Osama. Salam. So thank you for this kind invitation to be here with you, unfortunately, online, and to discuss about the faster Aspart and innovation in the Prandial insulins. And in the next maybe 20-25 minutes, I would discuss some of the studies and where is the place of the new insulin, like the faster Aspart. So if you have any questions, please use the chat box and ask, or if you have any comment, and at the end we'll have time in this short period to answer and to comment your questions or the comments. So let's start. Yes, this is my disclosure. And let's discuss a little bit about the burden of the mealtime dosing. Actually, we all know that in the last couple of years, when we have the CGM devices, when we have the insulin pump therapy, with all these new improvements in the innovations in the diabetes, we are not talking more about the glycemic control. We all know that this can improve the glycemic control. But now we are going further to improve the quality of life of this patient. And we all know that there is a burden of the mealtime dosing. This is one interesting paper that was published last year during the ESD, European Association of the Study of the Diabetes, which explains the burden of the mealtime insulin dosing in adults and children with the type 1 diabetes. When they analyze the data from the adults and the parents of the children with the type 1 diabetes, they found out that the frequency of the completely forgetting to take the mealtime insulin is huge. As you can see here, that almost 11 or around maybe 10% they are forgetting at least once per week to give the insulin. And there's also some percentage that on the daily basis they are forgetting to take the insulin. And of course, this is very, very difficult if you are a parent of the child with the diabetes, and then when you have to administer the insulin 5-6 times per day, that you need to do all these calculations and that you give the insulin even before the insulin. So from this survey, 25% of the adults with the patients and almost 40% of the parents with the children with the type 1 diabetes, they are completely forgetting to give the insulin the pre-meal at least once per week. So from this study, there is also an interesting data which shows what is the preferred timing of taking mealtime insulin when you give the choice. As you can see, most of them, they want to give the insulin immediately before the eating or maybe immediately after the eating. So doesn't matter if it is the adult patient with the type 1 diabetes or it is a parent of the children. So what is the perceived impact of the quality of life of being able to administer the insulin either immediately before or after the meal? So as you can see here, almost 70% of the adult patients and almost 72% of the parents of the children with the type 1 diabetes, they claim that the taking bolus immediately before the meal or after the meal would have the positive impact of their overall quality of life. And I think that this is very obvious. If for the patient with the type 1 diabetes, doesn't matter if it is adult or a child, they're taking several boluses. And we always are saying to our patient, yes, when you see some postprandial hyperglycemia, it's said, okay, you have to give the insulin 15 or 20 minutes before the meal. But if you eat 5 or 6 times per day with snacks, this is very, very unpractical. And this is actually how we can improve the quality of life with these patients with the type 1 diabetes. So let's discuss more about the science behind the faster Aspart. This is a very famous curve, how the insulin actually is working, and this is the regular human insulin. We all know that the onset it's maybe 1 or 2 hours, and then it take some time the insulin to be active, and there will be 6 to 8 hours that there will be the insulin on board for the regular insulin. And it makes a little bit difficult if you want to give the insulin in between here, that the patients who are not using the insulin pump therapy, they have to consider, yes, I'm 2 hours post-prandial, so I have to consider that there is some active insulin on board. And this is how does it look like the insulin from the normal pancreas. It starts the onset immediately, and after 2 or 3 hours, it's almost gone from the body. The fast-acting insulin that what we have, they are moved a little bit right from in this chart, so they are here, and this is why we are saying that yes, you always need to give the insulin before, or sometimes 15 or 20 minutes before the meal, which is a little bit not practical. And look at the ultra-fast insulin, like the faster Aspart. So now the curve comparing with the faster insulin Aspart, with the fast-acting insulin, the regular Aspart, it's moved a little bit left. And this shows us that we can give the insulin immediately or sometimes after or during the meal. So it replaces the insulin secretion in the type 2 diabetes and have a better profile for the insulin pump therapy, because this is the continuous insulin delivery. I will not go into details about the formulation, but this modification in the formula of the insulin Aspart, because it's almost the same, but there is improvement because it's the absorption of the absorption. It's modified, so it's a quicker absorption, and there is also added the L-arginine for the stability. So when we compare the faster Aspart versus the insulin Aspart with the subcutaneous injection, this is how does it look like. With the blue line, the bolt is the faster Aspart, and this is the serum concentration after on the 4 minutes, 9 minutes, and the 30 minutes. Look at this shaded area here with the pink one, which shows how much how faster is the faster Aspart compared with the insulin Aspart. So twice as fast onset of appearance in the bloodstream, and twofold higher insulin exposure with the first 30 minutes. So this is the shaded area which shows the best. And of course, it's the 74% greater insulin action with the first 30 minutes of the action of the fasting. So what about the pharmacokinetics and pharmacodynamics in the special population? In children and adolescents with the type 1 diabetes, this insulin was associated with a twice as fast onset of appearance of the twofold higher insulin exposure with the 30 minutes. In children with type 1 diabetes, faster Aspart was associated with a significantly greater glucose lowering effect, and we're going to see that one in the next couple of slides. And there were no significant age group differences in the pharmacokinetics and pharmacodynamics parameters between the faster Aspart and the insulin Aspart. These are the licensed indications: treatment of the diabetes mellitus in Bahrain. In Qatar, I can say that we managed to have a wider application, so it can be used in the adults with the type 1 diabetes, adolescents, and also children with the age of 1 above in Qatar. Additional information that this subcutaneous administration up to 2 minutes before the start of the meal, with the option to administer up to 20 minutes after the starting the meal. This is what we are usually giving the information to our patient, to the parents, those who are a little bit afraid that of the hypoglycemia, especially for some of the parents, they want to give the insulin after. But with the time, when they will be more confident when they are starting with the insulin after the meal, that there is no hypoglycemic events, they will move during or before the meal. And of course, it can be used during the pregnancy. As you can see here, that the portfolio of the clinical settings is wide. It's type 1, type 2 diabetes, multiple daily injection in insulin pump therapy. Unfortunately, we don't have time to go over this all studies. We're going to show the data some of the study. And these are studies with the type 1 and also with the type 2 diabetes. Let's discuss mostly about the faster Aspart in the type 1 diabetes, the onset. This is the abuse He published this article 3 years ago in the Diabetes, Obesity, and Metabolism. This is the trial design. It's not complicated. Actually, it was the double-blinded study. There were 3 different drugs. The patients were randomized after the 8 weeks of the run-in period. The first one was the mealtime faster Aspart and the insulin deglutec as a background insulin. The second group was the mealtime insulin Aspart plus insulin deglutec. So they just wanted to see the differences between the faster Aspart and the insulin Aspart. And there was also another group, which was the post-meal faster Aspart and the insulin deglutec. It was the partial double-blind type 1 diabetes, more than 1 year. Both genders were included, A1C between 7 and 9.5, and they should be not obese, more than BMI more than 35%. And the key endpoints was the change from the baseline to the hemoglobin A1C, 26 weeks after the randomization, and the change from the baseline in the 1 hour postprandial increment, 26 weeks after the randomization. And this is actually the hemoglobin A1C in the run-in phase. All 3 groups, they decreased the hemoglobin A1C from the average from above 8 to almost 7.5. As you can see here, that at the end of the study, when comparing with the hemoglobin A1C, there was no inferiority of the faster Aspart comparing with the Aspart. As you can see here, that the faster Aspart also it decreases more the hemoglobin A1C comparing with the regular Aspart. But this is also a very important point about the postprandial increment and the week 26. This is the regular, actually this is the insulin Aspart. This is the postprandial increment in the next 4 hours. This is how does it look like. And this is the bolus dose given of 0.1 units per kg. And look at the faster Aspart. Immediately in the first 30 minutes, the postprandial, it was significantly decreased. And the 60 minutes, it was even more higher. And after the 2 hours, of course, it was again a little bit more significant. And then it went after the 4 hours, similar to the Aspart. But I just want to focus and just to be focused on this area here, which shows the postprandial curve here, that it's very, very significant because it immediately decreases in the first 2 hours, which what we were expecting in our patient. Because usually this postprandial state, we are measuring after 2 or 3 hours. With the CGM, we can see also this area here, and we're going to see on the next slides that it's also improvement here. And imagine this is why I want to focus mostly on this slide, because if the patient is hyperglycemic in these 2 hours after each meal, and if there's a child who is eating 5 or 6 times per day, snacks and main meals, so that means that half of the day, 10 to 12 hours, the patient will be in the hyperglycemic states. So this is why it's also showing the improvements in the hemoglobin A1C. What about the hypoglycemia? Even less hypoglycemic events are also shown with the faster insulin, with the faster Aspart. What about the meal-related hypoglycemia after the 26 weeks? So it can be said that the faster Aspart, comparing with the mealtime Aspart, it has the less hypoglycemic events. Both are non-significant. This is a very interesting study, the Go-Bolus study from Thomas Dane from Germany. And in this year, he published one interesting article. This is the real-world population in the patient with the type 1 diabetes on the multiple daily injections using the flash glucose monitoring. Because with the flash glucose monitoring, we can see all these changes in the time spent in the time in ranges. So this is how does it look like. This is the flash glucose monitoring before including the study, and then they started the faster acting insulin Aspart given as the multiple daily injections. And after the 12 weeks and the 24 weeks, there was actually the flash glucose monitoring here. So the key inclusion criteria was the age more than 18 years, so adults with the type 1 diabetes more than 1 year, stable insulin treatment by the MDI for more than 6 months. Regular use of the flash glucose monitoring for the 6 months, because it's not only just to add the sensor, it's just to know how to utilize this kind of the data. And the primary objective of this study was the change of the hemoglobin A1C from baseline to the 24 hours, and the secondary was change of the hemoglobin A1C from the base to the 12 weeks, insulin dose, basal bolus ratio, and the QLA questionnaires. This is the extended analysis, which shows that there was improvement in the hemoglobin A1C by 0.2%. But this is the most important slide from this study, which shows that, look at here, the time in target range from 70 to 180, it was increased by almost 46%. So huge improvement in the time spent in the time in range. And this is actually coming from the previous slides that we presented, because the faster Aspart has more aggressive improvement action comparing with the other insulin, and there was also decrease in the time below the range and decrease of the time above the range. What about the type 2 diabetes, faster Aspart? This is the onset 9. Double-blinded, treat to target, so similar to the previous study, onset 9, but here are the only two arms: faster Aspart and the deglutec, and the insulin Aspart as a deglutec, and they were randomized in these two groups. Both genders more than 18 years, type 2 diabetes more than 10 years, and treatment with the basal bolus regimen more than 1 year, and the hemoglobin A1C from 7 to 2 years. The primary endpoint was the change from the baseline and in the hemoglobin A1C 16 weeks after the randomization, and they wanted just to see the change in 1 hour post-prandial increment. Again, similar to the previous study, the hemoglobin in the run-in phase, it decreased, and it stays almost the same comparing to the Aspart. So there was no inferiority confirmed between of the faster Aspart comparing with the Aspart. Again, there was a slightly more improvement, decrease of the hemoglobin A1C comparing using the faster Aspart comparing with the insulin Aspart. And again, this is similar to the previous study, the postprandial increment. You can see here that, again, similar with the patient with the type 1 diabetes, the faster Aspart has the it has more improvement in the postprandial state, especially after the 30 minutes to 120 minutes, and even lasting longer, up to 3 hours after that. And this is actually a significant difference in 1 hour change comparing with the Aspart. Both insulins, they were very good in the confirmed hypoglycemic events. They were lower, so no significant hypoglycemic events. But overall, with the faster Aspart, actually there was lower episodes of the hypoglycemic events comparing with the Aspart. What about the pediatric population? These are the children and adolescents, onset 7. Similar to the first study, actually they were randomized in the 2 groups: faster Aspart mealtime and the insulin Aspart mealtime in combination with the deglutec. And there is a third arm, which was the faster Aspart postprandial as a post-meal together with the insulin. So these were the both genders, less than 18 years old, hemoglobin A1C below 9.5, MDI for sure, and not using the real-time CGM system. And the key points was the change from the baseline in the hemoglobin A1C, 8-point SMBG profile, and a change from the baseline in the fasting plasma glycemia. Again, there was this is the hemoglobin A1C during the study. There was no differences between the groups in the hemoglobin A1C. they were almost a similar result at the end. And this is the change from the baseline in the 1 hour post-meal increment and the 26 weeks. As you can see here, that there was with the faster Aspart, there was improvement by 1 millimole, around maybe 20 milligram per deciliter after the breakfast. Mostly significant after the breakfast. It's similar in the male evening compared to the regular Aspart. Again, hypoglycemic events, there were no significant comparing with all three groups. These are the adverse events after the 26 of the other safety information, no significant. So it was the conclusion of the study that it was safe to use in the patients with the type 1 diabetes. So at the end, I would like to conclude with this with the following. Ultra-fast acting insulin have an earlier onset and earlier offset of action, thereby being more physiological. This offers more flexibility with regards to timing of the injection, thereby potentially improving the quality of life in the patient with the type 1 diabetes. Ultra-fast acting insulin provide comparable hemoglobin A1C glycemic control as rapid insulin analogs, with significant improvements in the postprandial control in the wider population of the type 1 and the type 2 diabetes using the multiple daily injection. I think that this is my last slide, and I would like to open the discussion if there are any comments from your side or if there are any questions.
Thank you very much, Dr. Petrovsky. Very interesting and very enlightening discussion and presentation. I've actually got a question for you. I mean, from what you talked about, it seems that speed and flexibility are maybe the key of what we are seeing here with this innovation in bolus insulin, Prandial insulins. But again, I guess with that, you've got to start to think to yourself, let's go beyond the clinical trials and get into the patient. So from your clinical experience, which patient subtypes would you think would maybe benefit from such a new Prandial insulin?
So I can say that, it's a simple, all can benefit, all patients can benefit. But the patient who is on the established therapy, when you have the good hemoglobin A1C, I also want to see the CGM, because the CGM will show you the postprandial curves that are a little bit higher. So those patients who are experiencing postprandial hyperglycemic events and even the hypoglycemic events, especially in children, because some of the parents are a little bit afraid to give the insulin before because of the potential hypoglycemia. They are giving the insulin after the other insulins. And what is expected, they will go into hyperglycemia and they will give the insulin, they will do the correction, and they will go to the hypoglycemia. I think that this is the group of the patient that can mostly benefit of this patient, and those who are also frequent eaters. Small children who want to have several boluses several times per day. And of course, in the pump therapy, it's also much better because it's not only the postprandial, it's also the correction, especially with the automated insulin delivery system. So you can play with active insulin time, so you can play to be the pump to be more aggressive. And in the first 2 or 3 weeks, maximum to 1 month, you can see this more aggressive, I can say, approach in the hyperglycemia reduction. And then you can have the hemoglobin A1C at 6.5 or 7.1, but you can have the amazing time in the range of 91% with this kind of the insulin, using the automated insulin delivery. So I can say that those patients who are experiencing this hypo and hyperglycemias, especially the postprandials, they can benefit, of this insulin therapy. And I can say, try it. And then you will see how it will work. And then every physician has its own clinical pathways, and they will find the way which patients are suitable for them. But from my point, this is the group of patients that can benefit a lot.
Lovely. And there's a question asking if it's licensed for use in pregnancy.
Yes, it can be used in the pregnancy. Yes, it's an Aspart, the basic one. So that means this is quite good that, you can use it in the pregnancy. And we are very humble because in Qatar, we can use it above the age of 1. So that means we have opportunity to use all the insulins.
Brilliant. And just one final question from a practical point of view. How easy is it to initiate? Is there anything different from, say, Aspart or from other bolus insulins if you wanted to initiate in type 1 or even type 2?
1-to-1. It's 1-to-1. I think that you keep the same carb ratio. Usually 95 of the patients are using the multiple daily injection with the basal bolus. So you just use the same carb ratio, 1-to-1 unit. It's a very pity because we are seeing some patients that are on the fixed boluses. This is what I don't like to see because you will not see the benefit of the therapy. So the patient should be on the multiple daily injections with the basal bolus therapy to see the benefits of this therapy.
What strikes me is, we've had a lot of innovations in the basal insulin side of things. Maybe there's been a bit of I won't say lag, but a delay, I guess, in any innovation seen in the Prandial insulin. So I guess it's a welcome change to see such a thing, and especially now with the timing of, as you mentioned, time in range again and again, and technology. And you're absolutely 100%
there's one question here just pop up here from the from this.
Brilliant.
Why there is no better hemoglobin A1C control than just the normal fast-acting insulin? I can say that this is a good question, and for me, I don't see only the hemoglobin A1C because in the last 20 years we're using the CGM. And that means, and even the Go Bolus study showed almost the same, 40% increase in the time in range. And those who are experienced in using the CGM devices, you can have the hemoglobin A1C of 7.5, and in some patients you can have 75% time in range, and in the other one you can have 55% time in range. So that means we have to look at the CGM devices, and then you will see the differences. And there are a lot of papers who are showing that we know that the hemoglobin A1C is the key corner for the glycemic control. But in the patient with the type 1 diabetes, I want to see the CGM device to see the time in range, because with the time in ranges, then you will see where you are, and then you will see a huge improvement in the postprandial. You just add the sensor for 2 weeks, and then you will see before and after improvements in the time in ranges. Maybe not in the hemoglobin A1C, but the time spent in the same hemoglobin in this normal glycemia will be improved.
Excellent. This is an interesting discussion. However, unfortunately, we do seem to be out of time. But with that, I'd like to thank Dr. Goran Petrovsky for a very well delivered talk and excellent discussion at the end, and of course for all the attendees and the organizers. And with that, I wish you very good luck with the rest of the Congress, and stay well, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you. Have a nice weekend.